Hi, everybody. It's Carin Andersen here with Aortic Hope for this week's Week in Review. If you're unfamiliar with what that is where we get a chance to show all of you some of the posts that we're putting up and sharing across our social media. So if you're just joining us here on our website or on YouTube, you'll get a chance to see some of the other things that we are also doing around the platform of social media. So our weekend review goes over everything we posted last week. And before we get started, I'm going to ask you to please click like, please click subscribe, and then at the end, click share, because I feel really confident that somebody else that's probably not even part of aortic disease might actually get some really good information and knowledge from our weekend review. So let's go ahead and get started. I'm going to go and share my screen. All right. We're going to get started with our Medical Monday. Medical Monday is always fun to do, fun to be part of. We love when our med students join us and share some really great, insightful information. This is from Ani, and for the month of April, we've been talking about aneurysms, and we talked about thoracic aortic aneurysms last week, but today we're going to be discussing abdominal aortic aneurysms. And it's interesting because it can often be called a AAA. But that gets confused in this community a lot because a lot of people seem to think that a AAA means abdominal aortic aneurysm, and that is just not true. It's hard. I know we want to think that it's that, but okay. So the abdominal, I think I just said the wrong thing. I think you just screwed that up. All right, so the abdominal, that's not what I meant to say. I meant to say a lot of people in the community think an ascending aortic aneurysm is a AAA. I just heard that on Rewind. Hey, it was only 22 weeks ago I had surgery, so my brain sometimes is slower than what's coming out. Okay, go back. A lot of people think a AAA is an ascending aortic aneurysm, and I totally get why you might think that, but it's not. It actually stands for abdominal aortic aneurysm, and this is really a condition where people, they might not have even heard of it, a lot of people in this community, but it's pretty serious if it's left untreated. But the good news is that when it's found early and monitored properly, it can often be managed safely. And here's a simple breakdown of what an abdominal aortic aneurysm is. We already know that the aorta is the largest artery in your body, and it runs from out of your heart up and down through your chest and your abdomen. And an abdominal aortic aneurysm actually occurs when a section of the aorta in the abdominal area becomes weakened and bulges outward, kind of like a balloon. Over time, that bulge can grow larger, and if it becomes too large, there is a there's a risk that it can rupture, and that's going to be a medical emergency. Here's a great diagram. Here is the aorta exiting the heart, coming up and over to the back end of the heart, behind the heart. This would be your ascending. This is your arch with your 3 branches that go to the brain and the arms. And then it comes down the descending thoracic. It's thoracic because it's still in the chest. Okay, this whole thing here is the heart. Now, it's going to come down and have renal arteries, which feed the kidneys. And this is all abdominal because there's other arteries that basically feed your entire organ system that's in the abdominal area. So that's going to be your spleen and gallbladder and your intestines and your stomach, all of that. And then it branches off into your iliacs, which feed down into the legs. So this is the abdominal aorta right here. Who's at risk? So it tends to be a little bit more common in certain people. And maybe that's why there are certain organizations that tend to want to focus on the thoracic aortic disease element only, because granted that is, especially the ascending has a much higher risk for a higher mortality rate because it has such high blood volume. But the abdominal aortic aneurysm can happen even if you've had something in the thoracic and vice versa. So don't rule out if you have something in the abdominal area that it can't happen in the thoracic. There is no door with a little guard saying, no, you can't cross the imaginary line to the thoracic. It's really important. This is one vessel. Learn as much as you can about it. But it is much more common, especially in adults over age 65, people that definitely have a history of smoking, people that have high blood pressure, and individuals that obviously have a family history of aortic aneurysms. And again, like with all other aneurysms, most people don't really have any symptoms, which is why screening and imaging is so important in these higher risk groups. So everybody likes to ask, are there symptoms? And most aneurysms are going to be silent, including those in the abdominal area, meaning that they don't cause anything that's extremely noticeable. But when symptoms occur in the abdominal area, you might feel a pulsating sensation in the abdomen. Now, don't freak out if you feel something right now. I know we're all touching our bellies. That doesn't mean you have one. But if you have one and it gets large enough, you could feel a pulsating sensation in the abdomen. And you might even feel some deep, steady pain in the abdomen or the back. Don't go freaking out if you have back pain or you have a bellyache. This is just what you could feel if you have an aneurysm and it's large enough. These are some of the things reported that you can feel. But how are these things diagnosed? It's pretty non-invasive. I mean, they're usually found incidentally or by accident through imaging tests that are done for other reasons. So that's typically an ultrasound, which is what's most commonly used for screening. And a CT scan or an MRI is used to give more detailed imaging of what might be going on. And screening is recommended for certain high-risk individuals, especially older adults with a history of smoking. It is highly recommended that you just go for a baseline screen. Now, how is it going to be treated? That really largely depends on the size of the aneurysm and how quickly it's growing. That's kind of the rule of thumb when it comes to an aneurysm anywhere, right? We kind of look at what's the size and how quickly does it grow. Small abdominal aortic aneurysms or AAAs, they're often monitored with regular imaging, like we mentioned above, and they're managed with blood pressure control and lifestyle changes, which means no more smoking. Larger or growing AAAs, they might actually require some type of repair to prevent a rupture. And there's two main types of repairs. There is an open surgical repair where the weakened section is replaced by a graft, or there is an endovascular repair, which is a less invasive approach using a stent graft that's placed through the blood vessels. And your doctor will have those conversations with you and work with you as part of acing your healthcare journey and part of advocating, communicating, and educating. You're going to want to discuss your options and kind of come up with that plan that's going to fit your lifestyle and what you basically feel more comfortable with. You'll discuss that. Okay. Why does monitoring matter so much and why is it so highly emphasized when it comes to AAAs? Even if it doesn't need immediate surgery, okay, regular follow-ups are really essential. Watching for change in size is really key critical, and it really helps ensure that treatment can be given and delivered before any complications occur. So the bottom line is an abdominal aortic aneurysm look, it's a serious condition, okay? And but the good news is it's often manageable, right? Especially if you catch it early. And most people, they live for years with very small, stable aneurysms under careful monitoring, of course. But if you're in a higher risk group or you have family history, talk to your doctor about whether screening is really going to be right for you. Stay informed, keeping up with follow-up care and your monitoring, and it really can make all the difference. So that was your Medical Monday, all about abdominal aortic aneurysms. Okay, everybody, we're moving on to our topic Tuesday. Now, this is all about aortic root aneurysms, okay? And we're talking a little bit here about when you have an aortic root aneurysm, we're going to get into the Bentel procedure. And are we looking at tissue versus mechanical? If there's something, I guess, involved with the valve. So let's take a look at and see what Tuesday's post is all about. So it actually looks like it's really not going to be about tissue or mechanical because we're talking about valve-sparing aortic root replacement. VSARR. You're probably not going to hear those acronyms, those letters. But an aortic root aneurysm. Now we've just gone the whole opposite direction. We just went from belly right to the root, which is exactly what it sounds. It is the most proximal part, closest part, proximal, at the level of where the aorta connects to the heart. Okay, so it's going to be closest to where it connects to the heart and surrounds the aortic valve. All that tissue that surrounds the valve, that is your root, or it should be down here more because then it's going to come up and around. Like most aneurysms, like we've talked about it, symptoms asymptomatic, okay? But it can really lead to life-threatening complications if it's left untreated. It could rupture. right? You can have a dissection. You can have a lot of aortic valve disease, heart failure. If it starts to stretch on the valve leaflets and it distorts them. Okay. This is why the aortic root is different than, let's say, the descending thoracic aorta or the abdominal aorta. So the aortic root is a dynamic structure. It's not static, it's moving. And why is it moving? Because it's got the aortic valve leaflets in it. So that part of aorta is going to move with the heartbeat. So it has encompassing tissue that expands to help accommodate the blood flow every time the heart beats and lets that oxygenated blood come out of the heart and go into the aorta. So that's why it's dynamic. It's always moving. And as the root dilates, it can actually stretch the valve and pull those leaflets apart, which actually causes the blood to leak backwards into the heart. That's called regurgitation. Okay. And over time, like the force of the heart, it's going to force the heart to work harder than it actually has to. And that could then lead to symptoms. Okay. And some of those symptoms could actually be heart failure. It also makes repairing these root aneurysms harder because one has to be mindful of whether or not the valve actually needs to be repaired in this process or removed, or it can be preserved, which is what valve sparing aneurysm repair is. Historically, the standard operation was called the Bentall procedure, and that's where you would replace the entire aortic root and the valve, and you would replace it with a new graft and an artificial valve. Essentially, you take everything out and you replace it with all artificial parts and material. It's highly effective, but patients who have had healthy valves were now subjected to these incredible limitations that come with having an aortic valve like a mechanical one, because it means you have to be on blood thinners. And uh, if you choose bioprosthetic, it could mean that it has limited lifespan or durability, which means a second surgery. That would be a tissue valve. So there's been this big shift towards valve sparing procedures. And a lot of times these valve sparing procedures happen when people have dissections near the root and the ascending. They're trying to find more and more ways of not involving that valve and preserving the valve as much as possible and like kind of tightening that up so that it's not regurgitating. So over the past few decades, these aortic valve sparing root replacement operations have really emerged as an attractive option for certain patients that have normal valve leaflets. And in order to qualify for one of these surgeries, the patient really needs to have true aortic root aneurysm, which is a dilation of the aortic root, and they should have a healthy aortic valve that can be preserved. Now, the benefits of this type of surgery is that you get to keep your own heart valve, and keeping anything that's natural to your body, native to your body, is a really good thing. You preserve native valve blood flow and the dynamics of that. There's a lower risk of prosthesis-related complications such as infections, higher durability than having to have a tissue valve because you're keeping your own. And that ultimately can give you a higher quality of life, especially when it comes to younger patients. And the two main approaches for valve space sparing aortic root replacement is something called the David procedure, which is actually reimplantation, or I hope I'm pronouncing it right, is it Jakob or Jakub? I'm not a doctor. I'm just trying to pronounce the words, but it's remodeling, okay? Both of these procedures, they each have their own drawbacks and their own benefits that are really beyond the scope of just this post, but you can look it up and we're going to go into it, obviously, at some point in the future. However, the success of these surgeries really depend heavily on the patient selection and the surgical expertise. So that includes leaflet quality of your native valve, the degree of annular dilation or aneurysm size and underlying disease process, all factor into decision making on how this surgery is going to take place. So definitely be sure to ace this healthcare journey by asking your surgeon about their experience performing these operations, these valve sparing operations, and how their patients are tending to do afterwards. Centers or hospital systems that are comfortable doing these procedures are going to have data to back it up and will happily share their experiences with you. So That's kind of it for today's Topic Tuesday. A lot to digest. But it's nice to know that there is an option of sparing everyone to have to maybe have that valve replaced when they have to have surgery done on the aortic root to repair that aneurysm. So it's always good to know that you have options. And that's your Topic Tuesday. Okay. All right. This past week was leading up to a lot of what's going to be going on right now in this current week. And one of them is welcoming one of two new volunteers that came on board last week with Aortic Hope. And the first is Jason Beatty. He's going to be our new YouTube producer. So what does that really mean exactly? Well, one of the changes for 2026 is we're not really going to be doing a lot of live productions. We're going to be taking questions for the lives that we're going to have with our physicians ahead of time. We are recording a lot more, as you can see here. We've just studied the stats and we've realized that confining people to a certain time frame when they have to watch is we have more viewership afterwards. So if we're going to have more viewership afterwards, that means I can record, anybody can record, and we have time to edit and really zhuzh it up and make it look spectacular. So that's just what we're doing right now. That could always change in the future. But we don't have enough hands on deck to really help with making sure that all these recordings are taking place. So Jason has stepped in and he is just lovely. I had a chance to meet him at our most recent fundraiser. He's really going to be helping us when it comes to recording and editing for our AHTV, a lot of these on-air talent. And I'm going to tell you a little bit about Jason from Jason's own words. I'm Jason. I'm 45 years old. I live in Hagerstown, Maryland, with my lovely wife and two cats. I enjoy fishing, thrifting, and walking on the beach looking for sea glass. I had my aortic dissection in October of 2024, and I'm looking forward to giving back to this community that has helped me get my life back. So everybody, please take a minute, if you would, and welcome Jason. Okay, we're going to take a break before our next volunteer, and let's talk about our Survivor Series replay. And this one was with Kevin Gibson. This was a video, so you need to check this story out. You need to click here. If you get to our post on our website, Kevin's story, as with everybody who shares their story, is brave, insightful, vulnerable, humbling. And we're so happy that Kevin was willing to contribute to the series. What makes our Survivor Series different, and we've been doing them now for about 9 years, almost 10 years, is that we don't interview anybody. We don't want to have to keep asking the same questions of everyone that participates, which is really the only way to make it make sense, is to hear the different answers. We leave it up to you, the survivor or the caregiver or the person who might have lost a loved one or a friend. We leave it up to you to tell your story in your words. So you can do this in written format, or you can be pre-recorded with us here. It doesn't matter. We just want you to be the shining light in someone else's life. It's been proven time and time again that when you share your story, it's not only a validating experience to someone else listening, but it can be quite therapeutic for yourself just to kind of get that out and get that off your chest. Don't be surprised if we don't share your story with Think Aorta US, as they are looking to educate the emergency room physicians more and more about the nuances and the differences between people with aortic disease and how we present. We also use it as a tool on the importance of sharing your medical history in your family. These concepts are described many different words across the United States and the community, and it comes down to two simple words. We are getting people to think aorta. Because if doctors weren't thinking about the aortic hope wouldn't be here. Half the other organizations, they wouldn't be here. So when the doctor remembers that these dissections, they're presented differently, aortic disease in general, aneurysms and heart valve disease, which are so much more common than you think, when they present differently, it's important to pick up on those subtle cues. It's important for us to talk about that medical history. And when you're in doubt, just go check it out, right? Ask your physician for a baseline. It's why it's so important to think aorta. So there's links here on our blog. There's also under programs, you'll see there's links to be part of our Survivor Series. And we also ask people to share a little bit about where they are now, hence the name, Where Are They Now? That is a series we started 8 years ago. And that just allows people to kind of talk past the aortic disease if they're able to, right? I mean, only if they're able to, and really talk a little bit about where they are in their process of recovery. Have you been blessed to see milestones in your life through your children, your grandchildren, your friends, your siblings? Go back to work. That's such a big milestone, right? Did you run a marathon since? Are you struggling and life just never really got to get rolling yet for you? Haven't found your new normal? Every answer is correct. And we just want you to share it with everybody because, again, it's going to be very validating for those of us that get to hear your story. So that was this week's Survivor Series replay. And now we're going to go right back to welcoming another volunteer. This one is Community Liaison Jeremy Porter. Now, what's great about Jeremy is he's coming to us from Canada, where our other location is our Aortic Hope Canadian groups. And based in Canada, he's working alongside two other individuals here in the States to help bring our third patient guide to life. And it's going to be called Aortic Hope, Real Stories, Real Recovery, Real Life. And we're going to talk more about that another day. But actually, we'll talk about it today. We're so super excited to have him on board. Not only just coming from Canada gives us a whole other perspective, right? And this is a joint North American effort. It really is. And it's really helping us expand our global impact. So here's some words from Jeremy, and I quote, "As are many, I was unaware of what an aorta was until days after experiencing what I later learned was a type A aortic dissection back on December 7th of 2024. So right around the time of Jason. I remember reluctantly getting to my local hospital, which was in Halifax, Nova Scotia, via ambulance, not wanting to be a bother to the 911 respondent, to emergency staff and hospital team at large. After 16 shots of nitro, wow, things blurred. And yeah, days after surgery, I began working through what had happened when alone in that Starbucks parking lot, given information from the hospital care team and my family, who all helped fill in the gaps. See, stories matter. Sharing your story matters. Mine certainly has much more ups and downs, which I'm sure your stories do too. In fact, I know it. I've learned through many of your posts on these social media feeds and through incredible resources via Aortic Hope, such as Therapeutic Thursdays, Canadian Support Group, etc. Personally, I'm about 16 months past my surgery and I'm still learning. I think he's a little bit more past his surgery. Yeah, I think this might have been written before. He's still adjusting. To do so, he turns to our stories. He turns to stories. Yes, early in 2025, Carin, I posted asking for volunteers to work on this third patient guide. And the vision was to reshape and share stories post-aortic event to help those that are new in the community adjust, learn, and when ready, move forward, knowing that despite the facing quite rare health scares, they're far from alone. While medical data is aplenty regarding aortic dissection, consults with our medical team are crucial. And in my opinion, so too are sharing our stories, as through them, we all learn from the commonalities of our ups and downs as we enjoy our new leases on life. I am proud to be one of the volunteers behind this third patient guide, and I'm appreciative of everyone who feels comfortable to entrust us to highlight your stories in Aortic Hope. Be well. All right, that's Jeremy. Welcome, Jeremy. Okay, that brings us to National Volunteer Appreciation Week, which started on Sunday, the 19th, which when you're seeing this, it was yesterday. And so we begin, if you take a look at this handsome, beautiful group of people, we begin by honoring our board volunteers and community. So during National Volunteer Week, we want to extend our deepest thanks as an organization in its entirety to our dedicated board of Aortic Hope and to every volunteer and community member who makes our mission possible. To our board, your leadership, vision, and commitment guide us forward each and every day. To our volunteers, your time, compassion, and willingness to serve bring our work to life. And to the community, your strength, support, and shared stories are the heart of everything we do. It takes all of you working together to create hope, spread awareness, and support for those impacted by aortic disease. We are endlessly grateful for each of you. Thank you for showing up, for caring deeply, and for being just such an important part of this community. And here are the dedicated individuals that are the backbone of Aortic Hope. We begin with Bill Barnhart, moving on to Deb Oxborough, our treasurer, Terry Cook, our president, Molly Thomas, this would be myself, founder and chair, Sarah Copeland, Deb Jolly Wacharlik, Jenny Schaefer, who is our VP, and Rob Seltzer. With heartfelt appreciation from the organization of Aortic Hope. That's kicking off National Volunteer Appreciation Week. All right, let's talk real quick about our events coming up. So when you go to our events page as of today, because we are working on creating a little bit of changes to our website, all of these things in red are links. So if you want to join one of our many support group meetings, here's where you do it. Caregivers only caregivers. You would join and you can attend the first Saturday of every month at 10 a.m. and the second Wednesday at 10 p.m. Everybody, caregivers and patients can click here and join to be notified via email every time we have a meeting. By the way, once you sign up once, you're going to get an email notification with a link to join just prior to the start. And so the general meetings take place the first Tuesday of every month at 12 p.m., second Tuesday at 10 p.m., and the last Wednesday at 7 p.m. And be mindful, all of these times are Eastern Standard. Canadian support group meetings are the first Wednesday at 6 p.m. And then we do have our bereavement support group meetings, which happen every other month on the second Thursday at 7 p.m. Our next one starts in May. Okay, so where are we? Today is the 19th. Oh my goodness gracious, I'm recording this before the 20th, which is our week in review, and there I am. The next event we have is the 27th. We have another week in review with Molly. We have our WISE meeting, Women Inspiring Support and Empowerment. Now, if you click here, it'll take you to a forum where you can join only the women and be part of this hangout type of community connection for just women. And then on the last Wednesday, we have our support group meeting. We have a lot of different things coming up during the month of May, so keep your eye out for that. And we're going to go and mention to all of you, we've got such great sponsors already for the year 2026. And we want to really highlight Cook Medical. They innovate and manufacture quality medical devices to really help improve all of our lives in the aortic disease community. They focus on bringing compelling products to the market and keeping existing ones relevant. With headquarters in Bloomington, Indiana, and global manufacturing facilities, they aim to increase their impact worldwide. And then there's Edwards Life Science, which I'm getting really excited because I'm going to be attending their Patient Experience Day. They're a global leader of patient-focused medical innovations for structural heart disease and critical care monitoring. At Edwards Life Sciences, they listen to patients talk, and that's because patients really have an opportunity to provide them with information about our experiences, which can help them really improve their product. I love when companies want to listen to what we have to say. Our stories end up inspiring them to continue to fight on our behalf, right? That's great champion in our corner. And we also have an opportunity to provide comfort and support to each other when they can help us connect. I'm going to let you all know what the Patient Experience Day is like in June, because that is happening in June. So I will be sure to schedule myself a chance to have this week in review and share a little bit with you. I'm not going to share too much because from what I hear, it's pretty magical, and I want to keep everything quiet and under wraps. All right, so we want to thank Cook Medical and Edwards Life Science for sponsoring this week's Week in Review. Now, that, my friends, is the end. I'm going to stop sharing my screen and say to you, please don't forget to click like and click subscribe. Okay, when you're done, click share. If you'd like to leave us a comment, please do so. We do check it. We do write back. And I guess until next time, thank you guys so much for joining and for checking this out. And we hope to see you again soon. Take care.